Okay, so I think we should review that, because if it's a brand new contract, then I think it would be clearer to us, and it would make better sense if it came out as a brand new contract. 'Cause I think what we're used to seeing in the vendor report, and this is just because for these years now, or these months, these have been amendments or changes, which then have made it reasonably easy to then do it as a summary. But I think as a brand new contract, I'd see if we can consider doing it as a regular contract report. If that creates more problems, we can discuss that and
No,
discuss it.
that's totally fine. We can do that.
Okay. So the next was, without asking for, because Health Right 360 is a very large organization with us, with about 48 million plus COVID work of about 11 million, which is fine. And we had talked about one day reviewing these large contractors and understanding the services and the scores that they get as their evaluation. So in this case, I just sort of needed to understand that for the different evaluations that have been occurring, that Health Right 360 has been really a performer for us, that they are a good agency, because these services are very important.
Right. Yeah. So as you mentioned, typically I don't do the monitoring scores for the contracts that are not before you, but I did go back and check. I didn't have time to bring them off to a report, but I did go back and check on all the contracts that are not new, and there's several in here that are new that don't have a monitoring report, but every one of them is in compliance and meeting the standards. So we were there with you pretty recently for the check writing. No problem. The fiscal intermediary came to you in November 2020, and they were in compliance. The residential step down, that's the mental health, that's a big $22 million contract. At their last monitoring, they've met all the criteria and there's nothing that's outstanding. Street crisis response is new, that's today. Plan Tree housing program, their monitoring report was commendable in all categories and no issues were identified. The program, the next one, there's actually no direct services. So that one we haven't before, but we're going to be monitoring that with fiscal and compliance objectives, which just really means that they're complying with our needs and providing the reports. And then the CHEP ones are no problem. The next three are COVID-19, so there is no monitoring for those. So I think you can feel comfortable knowing that adding this program is not going to tip any scale because they're doing a good job.
Very good. And so the way this description reads, is this part of the overall program for SF Mental Health?
I will turn that to Angelica.
Hey, Commissioner, it is one of the programs for Mental Health SF and is our first program that we're launching under Mental Health SF. Of course, there's a number of different programs under Mental Health SF that'll be launched. And I'll just note we're also doing a full presentation of the street crisis response team at the full commission meeting on the 16th.
Oh, wonderful. Thank you. And I think this is a wonderful preview to see that we're moving forward on this very important program in spite of the COVID crisis. So, Commissioner, is there any other question, or are we prepared to have a motion?
Actually, sir, because this is the report, let Ms. Ruggles finish with the other contracts before you all go to a vote.
Oh, you want? Oh, okay.
Right.
True. Okay. Now I've got to get this screen back. All of a sudden, certain things have popped up, and they've popped in front of your face. Okay, there we are. Thank you.
Sure.
Sorry for the technical problem. Okay, that's right. So on the contract report, we take them all, but we do ask for public comment on each item, right?
Yeah, actually, I was wrong. It's at the end of all of it, so I won't ask for contracting Roger at the end. But
okay.
So it seems like let's move on to the next contract on the report.
Okay.
Okay.
Good.
The next contract is UCSF Regents University of California contract with Alliance Health Project. The requested action today is an approval of a contract amendment, and this will extend the contract by 1 year, and it will add the corresponding funding to extend it by 1 year. It also is adding carry forward funding that was moved from a different contract into this contract. So we've exceeded our contingency value and therefore need to, increase the not to exceed amount. The other thing that we'll be doing is moving also from another contract, the year 2 funding for an add back, 189,000, and that's used for the long-term survivors program, I believe. If you have questions, we have Dean Goodwin here, who's the Assistant Director of HIV Health Services, to answer any further questions.
Thanks, Ms. Ruggles. Commissioner Schaub, do you have a question?
You have Commissioner Brunel, do you have questions?
I do, thank you. Mr. Goodwin, 2 questions for you. The first is, does the addition of the 189,000 plus funding from the Board of Supervisors add back to target long-term survivors mean that long-term survivors were not previously served through this grant?
Commissioner, that funding was on a different grant. It was on their larger outpatient mental health contract. That's where that funding was in previous years. We are nearing the $10 million cap on that contract and needed to add this to a different outpatient mental health contract that AHP has. We'll be going to the board here in the next couple months to request approval to go beyond the 10 million cap, and that funding will either reside here or move back to the larger outpatient mental health contract.
Great. Thank you, Mr. Goodwin. Second question, part of the target population are those who are new to San Francisco. Is that mainly focused on connecting them with care within the city?
Yes, and making sure they're having their mental health needs met. This contract, the original part of this contract is for the getting to zero focused intensive case management, and there are many new to the city clients and that are out of services and need to connect, but also largely broadly making sure we're meeting the mental health needs of all folks, new or long-term residents.
So also connecting with primary care providers so we can ensure that they're in treatment, getting to viral substitution, et cetera.
Absolutely. And the intensive case management program has an acuity scale that's applied as clients are referred to the program to demonstrate need for that higher level of support.
Great. Thank you, Mr. Goodwin.
You're welcome.
And because this is an extension, I'm assuming that they have been performing well and that we're pleased to be able to continue to work with the Alliance and to add these services.
Yes, that contract, you have the performance scores, and they have an overall program score of 4, which is the highest. And I don't know if I just cut Dean off, but that is on your, sorry, Dean, that's on your review that their monitoring was perfect, just about.
Well, it sounds very good. Okay, so I have no further questions. These are obviously important services being carried out for many years by the AHP. So is there a motion? Oh no, we're just moving on and then do a motion totally. So shall we go on to the next contract?
Thank you.
Okay, the last contract on the contract report is PHFE doing business as Haluna Health. So this is a COVID-19 contract or emergency contract, and the ordinance number or chapter number is 21.15 of the admin code, which is what that reference is. But what we are doing is creating a new contract. Back to your other, but you probably, well, anyway, this is a new contract. It's replacing an existing contract which we set up under as a result of COVID. And we actually just, were given permission under the mayor's recent Declaration 36 or something to be able to amend emergency contracts. But what we've done with this contract is we're creating a new one because we have gone through and made sure that the scope aligns with the services that are continuing. And specifically what Haluna Health has been doing for us in this contract is hiring on our behalf to support staffing needs, primarily at the COVID command center or physicians at the field care sites. So helping us do the recruitment or bringing on staff, not as much consultants in this contract who are specifically hired to help with central command where there's missing civil service capacity or an expert out there that is providing help. And if you have more questions about this particular contract, Hallie Hammer is here to assist.
Commissioners?
Any questions?
No questions here, Commissioner Chow.
Okay, I guess my question here, however, now Dr. Hammer is here also, is that how does this function? That is, how is it decided that we would pull from this requisition for certain workers as versus having our disaster worker program coming from the different parts of the city? I mean, who actually is involved in making that type of determination and therefore, pulling from this contract?
Yeah, that's a great question, Commissioner Chow. We developed this contract around the time that we were needing to set up alternate care sites in preparation after our first surge, in preparation for subsequent surges when we may run out of hospital and emergency room capacity. And so the contract was developed in order to staff our field care clinic primarily, and then also in order to fill some other sort of skilled roles that we were having a hard time filling through the usual DSW deployment process. So as you know, for example, Department of Public Health employs the vast majority of licensed clinician positions in the city, and so it was near to impossible to get any significant number of like ED or urgent care trained nurses, physicians to staff that field care clinic. And then to fill some of the other roles that we've been able to recruit for through the Haluna contract.
All right. So in follow-up to that, then this contract is used as needed, and therefore this is the max amount that the contract would allow pulling. But if we're not pulling from this, then we're not hiring. I would assume that's true, right?
That's true. I mean, we have preferentially deployed BPH staff, other DSWs from throughout the city, and then drawn on staff from other mechanisms to fill these, again, largely clinical or highly skilled positions. And so we've just used the Haluna contract when we haven't been able to fill those critical gaps.
Could this then be used? We know that we're really short of people within the department now that have been deployed to the COVID center. So does the COVID center then take that into consideration and believe that like project A, B, and C really should get going? So I'm going to use this contract in order to bring back some of the skilled people that we need, and particularly in our department.
What's been so interesting over this past year, I mean, there are a lot of things that have been interesting, but one of the things is just the creative ways that first of all, how everything changes from month to month in terms of what the urgencies are, what we're trying to staff up. And then the command center and the DPH as well have been really creative in thinking about how do we staff up for this emerging really urgent need, for example, during a surge, contact tracers, case investigators, and then shift over to, like now when we need more frontline clinicians to provide vaccines to as we ramp up our vaccine operations. So, and we've drawn on different sources for staff for those emerging needs. This is one option. I actually like reading the tea leaves, what the near future will look like. I'm not sure we'll need a big influx of licensed clinicians going forward because of what we imagine our needs are going to be in the for the near future. Vaccination, vaccinators, line managers, contact tracing, outbreak management staff. I mean, those kinds of things we have figured out, I think, how to fill the staffing gaps for the most part. And so I think through the DPH and DSWs and volunteers, as well as some retirement hires, I think for the most part we're in better shape now than we were earlier in 2020.
Very good. Well, I'm glad we have a backup at least for here and the ability to try to find the people we need in order to maintain the effective program that you've been all working on. So thank you. I don't have any other questions, so I think we're prepared for a motion on the contracts report.
Motion to approve.
And I would second that as a recommendation to our full commission.
Thank you, Commissioner. I'm just going to verify that there's no public comment, just in case there is. If you'd like to comment on this item, please press *3. Raise your hand. Okay, there's no comment. Thank you, Commissioner. And now we can move on to item 4, which is a new contract request with AeroScout.
So I'll just introduce it to say, and then I'll turn it right over to our DPH representative, Jeff Angst. But this is a new contract with AeroScout for software licensing, software and equipment maintenance. The total contract amount is $1.680,000 with the contingency, and it would be a 5-year contract. And I'll just turn it right over to Jeff.
Scout is a.
Mute.
How about now?
Perfect.
Can you hear me now? I think it's a little lag. Apologies. AeroScout is our software platform that we use at both our hospitals and DPH to keep track of patient location as well as other assets that maybe are high value. We've been using it at each hospital. Laguna Honda Hospital's had it for about 10 plus years now, and it's also been at the Zuckerberg San Francisco General Hospital for about 5 or 6 years. My team is responsible for supporting the system, but when things aren't quite right or we need help, we reach out to Stanley Support. And so this contract will basically allow us to keep doing that. In the past, we'd done our renewals through the technology marketplace, but this contract lets us go directly to Stanley. Any other questions?
Rick, Commissioner Burnell, any questions?
No questions.
Okay, I guess my question is why in the proposed model that you have that Laguna would be more expensive than Zuckerberg? Is it based on beds or more needs, or what might be the reason for the difference in costs?
That's a good question. The answer is that Laguna Honda has a bigger footprint of the hardware that tracks the patients and some more integrations with Epic, our health record system. So it's a little more complicated. It's also got more patients that are being tracked.
Okay, no, thank you. And as I understand it, we have been working with these people through a different type of contracting mechanism, and therefore they're not really new in terms of the work they're doing. And it sounds like you've all been satisfied with what they're doing. Is that correct?
Yes, that's correct.
Okay. Is there any public comment?
Folks on the line, please press *3 to raise your hand if you'd like to comment on item 4. No hands raised, commissioners.
Okay, so I think we're prepared for the motion on this one,
Motion to recommend to the full commission.
and I would second that, and therefore we'll recommend it to the full commission.
Thank you, commissioners. And as we noted before, I'll say it again, we will be moving item 5 until the end of the meeting. We'll move to item 6, which is the new contract request with Cornerstone Technology Partners.
I will introduce this. I didn't see Mark on the, do you see Mark at church?
Yes, here.
He is there, okay. So I would just, this is a request for approval of a new contract with Cornerstone Technology Partners. It's 1.2 million, which includes a 12% contingency, and it's a 42-month long term. And I will turn it to Mark, and we also have the vendor, I believe, on the line if you have questions.
This is Mark of Church. The software that we're talking about here is by a vendor called Medi-Cal. We're going through a city store vendor, Cornerstone. The purpose of this software is providing a new service. This is a critical service. This software basically enables us to inventory all of the medical devices that are connected to our network. Not only does it allow us to inventory these devices, it provides a critical service in that it permits us to establish a baseline for network communication, as well as the frequency and type of communication. An example would be, every day on the hour, a drug pump administers, 100 milligrams. If it suddenly administers 1,000 milligrams, we would immediately receive an alert and be able to intercede and take that device offline and investigate. So basically, this is a software and a service that provides us Internet of Medical Device capabilities, something critical in this, unfortunately, a critical tool in our cyber toolbox, protecting our medical facilities, employees, and patients.
So, Commissioner Burnell, any questions?
No questions, Commissioner Cho.
Okay, so my question is, what did we do before this? Because it sounds like it's a sort of a critical need.
So, excellent question. And unfortunately, the answer is we did our best to leverage the tools at our disposal to minimize our risk and exposure. We've been fortunate in that we haven't experienced any incidences, but the answer is we made an effort using the tools we have, but they are inadequate, and this basically is establishing a baseline of a minimal necessary protection.
Does this integrate with the EPIC programs then, or it's actually sort of freestanding? It may be that it doesn't have to integrate with EPIC at all. That is, how you have a central way of monitoring these, or I'm kind of fascinated. Yeah. Me in a house, so, right? We have people trying to monitor things. How would you do it in the hospital?
So the application out of the box provides its own console, and we can grant people access to that console. But our contract with them includes setting up, configuring interfaces to some of our other tools. So we've already configured the interface to ServiceNow. We're working on the interface to Checkpoint, and then we also will be working on the interface to the tool that the biometrics team relies on operationally. but not Epic. Right now, we are not looking at uploading any of this information into Epic, and I'm not sure that Epic would be the tool that we would want to load this data into, as Epic is not necessarily oriented at this time. We don't have the Epic module that focuses on medical equipment.
Okay, because I guess one day, and what I was thinking of was, right, people are talking about like remote monitoring at the bedside, and then these would go into your charts and all. But this would seem to be actually an important function. It's, you know, I'm actually missing the detail here, but I'm just curious. The total amount is 1.2 million. So that is through 3 years. Is that right? I mean, that's you know, like about $400,000 a year. Is that?
That's correct.
Oh, okay. Because I'm sorry, I had for some reason misplaced a summary of the contract. But okay, well, sounds like a very a low price for the type of work that it is supposed to be monitoring. So. Commissioner, is there a, is there any public comment on this?
Folks on the comment line, please press *3 if you'd like to raise your hand to make a comment. No hands raised, commissioners.
Okay, so commissioners, we need a motion to recommend to the committee, to the commission.
So moved.
Thank you, and I would second that, and that will then get recommended to the full commission.
Thank you, commissioners. Item 6, we can move on to is, no, I'm sorry, we just did that. We can do item 7, which is the draft 2018-19 charity care report. And let's see, I think hope everyone's here. Mr. Maxwell is going to present.
Hi, Mark. Can you see my presentation?
Yes, great. Oh, actually, could you do slideshow? I see it on the screen, but it's not on slideshow yet.
All right.
Great, perfect.
Wonderful. I'm going to get started. Good afternoon, commissioners. My name is Max Guerra, and I'm a health program planner with the Office of Policy and Planning. Today, I'll be presenting a draft of the 2018-2019 Charity Care Report. I want to mention that I'm joined today by several representatives from hospitals who participated in the work group and are available to answer questions about trends about their hospitals if needed. So for this presentation, I'll first provide background on the Charity Care Ordinance and review the charity care landscape in San Francisco. And then I'll go into the annual report and provide information on citywide trends and also hospital-specific trends as well. This report is normally compiled and presented on an annual basis, but due to COVID-driven delays, this year's report combines 2 years' worth of reporting data. So the Charity Care Ordinance in San Francisco was passed by the Board of Supervisors in 2001, and at the time, this law was the first of its kind in the nation. The ordinance helps to increase transparency and accountability around charity care by requiring hospitals to report charity care data to the Department of Public Health annually, and also to notify patients of free and discounted services. There are 8 hospitals that report their data to DPH annually. 5 hospitals are required to do so per the ordinance. These include Dignity's St. Mary's and St. Francis hospitals, Chinese Hospital, CPMC, and Mission Bernal. 3 hospitals report voluntarily, and these include Kaiser, UCSF, and ZSFG. With these 8 hospitals together, DPH is able to more accurately capture citywide charity care trends. With regards to the notification requirements, every other year, DPH staff visits each hospital to conduct a review of the facility's compliance with the notification requirements. The next on-site review was to take place in 2020, but to reduce risks associated with COVID, the review was conducted electronically and each hospital completed a self-certifying checklist. All hospitals were found to be compliant. So before I start on the report, I want to highlight some events that have occurred since the passage of the ordinance that have impacted charity care in San Francisco. In 2007, the Healthy San Francisco program was started. This is the city's health access program that provides uninsured residents access to healthcare services. In 2010, the Affordable Care Act was passed, and in subsequent years, preparation was conducted for the Act's implementation. In 2014, ACA implementation began, and since then, we've observed an increase in health insurance coverage through the Medi-Cal expansion and covered California. This has been highlighted in previous reports. From 2017 to 2020, there were continuous efforts at the federal level to undermine healthcare access and the ACA. These actions have included the repeal of the individual mandate penalty and also changes to public charge rules. The report presented today covers data from this time period. I'll talk more about changes on the horizon at the end of the presentation, but starting in 2020, there have been significant events that are likely to impact this charity care landscape in the city. So moving on to the report itself. The report provides a high-level overview of charity care in our city and also showcases how these trends are experienced differently by the 8 reporting hospitals. Data is presented on both Healthy San Francisco and traditional charity care patients. Both of these programs have been defined on the slide on the right. For the report, representatives from all 8 hospitals were engaged to discuss the draft prior to presenting to the Health Commission. And as I mentioned at the start of the presentation, due to COVID-driven delays, this report combines 2 years worth of new reporting data instead of just 1. And lastly, for the first time, 3 years of health coverage and demographic data was collected for traditional charity care patients in order to better understand this population. So this slide highlights the 3 major citywide key findings that were found based on the analysis of data, and I'll go through each of these in the subsequent slides. First, the report observed a rise in charity care for the first time since the ACA's implementation. Second, we continue to see distinctions between the Healthy San Francisco and traditional charity care patient populations. And lastly, using new data, the report provides a better understanding of who the traditional charity care program is serving. So as I just mentioned, for the first time since the ACA implementation, there was an increase in the number of charity care patients. The figure on the left shows the number of patients receiving charity care. And over the previous 2 years, there has been an increase of 51% in patients served. The figure on the right provides an overview of charity care utilization by service type. And over the past 2 years, all charity care service types have increased, with emergency and outpatient services increasing the most. The next graph shows charity care expenditures and Medi-Cal shortfalls over the previous 5 years. And just as background, Medi-Cal shortfalls is the difference between the expenditures for Medi-Cal services and the reimbursement received for those services. Hospitals will typically absorb this cost. Between 2017 and 2019, charity care expenditures increased by about 37%, and Medi-Cal shortfalls increased by 23%. The increases in the Medi-Cal shortfalls have occurred despite a modest decline in Medi-Cal enrollment across the city, which could suggest that healthcare costs are increasing faster than reimbursement levels from the Medi-Cal program. So when we dive deeper into the data for Healthy San Francisco and compare it to the traditional charity care patient population, there are several differences to note. First, you'll see that the proportion of emergency care is greater for traditional charity care patients compared to the Healthy San Francisco population. This data supports the contention that Healthy San Francisco patients have greater access to primary and preventative healthcare services. Second, we see that the observed increase in the charity care patients overall was driven by traditional charity care patients. During this time, the number of Healthy San Francisco charity care patients remained relatively stable. This suggests that there are populations who continue to rely on Healthy San Francisco for healthcare services, likely due to ineligibility for ACA-initiated health coverage. So based on the analysis of data in the report and on our discussions with San Francisco hospital representatives, multiple factors were identified that could be contributing to the increase in charity care observed in San Francisco. I do want to note that we have limited local data to pinpoint the exact impacts from these factors. First, hospitals have reported that as they have increased their overall levels of service in San Francisco, they have commensurately increased the amount of charity care being provided. And as there have been increases in these healthcare services, the price of healthcare has also been, increased. This is also sometimes referred to as healthcare cost inflation. Over the past 2 years, healthcare prices have increased 7%, likely impacting charity care levels. Another potential factor is that hospitals have reported that patients have remained in acute care beds for longer periods of time as placements into lower acuity settings are becoming increasingly difficult to obtain. Therefore, patients must be held longer before discharge, incurring higher charity care expenditures. Lastly, the largest provider of charity care in the city, ZSFG, amended its charity care and discount program in February of 2019 to end patient balance billing. These changes expanded patient eligibility, likely increasing the number of patients receiving charity care. I do want to note that it's unclear if federal efforts to undermine healthcare access have impacted charity care in the city, especially as California has acted to counteract many of these policies. So the next section describes who's receiving traditional charity care. The graph on the left shows that the reported residents of traditional charity care patients. San Francisco residents continue to be the majority of charity care recipients. The data also show that a large number of patients are homeless or have unknown addresses at around 15%. These breakdowns have remained relatively consistent over the past 3 years. The figure on the right is a map of charity care patients by supervisorial district. The darker areas represent higher number of patients who have received charity care. And following with years past, we see that the largest number of patients are from districts that have lower average household incomes, particularly those representing the Tenderloin, Soma, and Bayview. These neighborhoods also have some of the highest rates of preventable emergency room visits. So as I noted earlier, new healthcare health coverage and demographic data was collected on traditional charity care patients for the first time. Almost all hospitals submitted data for their patients. The figure on the left shows the racial ethnic breakdown of patients. The data shows that patients are more likely to be Hispanic Latinx or Black African American compared to the overall city population. When examined by coverage type, as shown on the figure on the right, we see that 32% are uninsured and that 68% have some form of health coverage, and this includes Medicare, Medi-Cal, or commercial insurance. The data supports the contention that many people receiving charity care are those who have coverage but are unable to afford healthcare expenses. Most of these newly collected data indicators do not shift from year to year, except for payer data. So over the past 2 years, we saw increases in charity care provided to those with Medicare and those who are uninsured, while those with Medi-Cal saw a slight decline. So stepping back and looking at this data in tandem with the data that's traditionally collected, we see that those receiving traditional charity care are those most likely to be experiencing some of the most significant health inequities and who have higher medical need. This includes people experiencing homelessness, people of color, and those of lower socioeconomic status. We also see that it's not just the uninsured being served by these programs, but also a high proportion of patients with some form of health coverage. So now I'll focus on hospital-specific data. There are a number of factors that may influence charity care trends across hospitals, including the patient's personal preference, ambulance diversion, among others. Despite these factors, most hospitals parallel citywide trends with regards to patients served, services utilized, and expenditure levels. For example, as seen in the figure on this figure on the slide, 7 out of the 8 reporting hospitals experienced an increase in the number of charity care patients being served between 2017 and 2019. Overall, ZSFG, as the county's safety net hospital, continues to provide the large majority of charity care in the city, accounting for 59% of expenditures and 61% of patients served. In this slide, the table shows each hospital's ratio of charity care costs to net patient revenue for the most recent year and compares them to a state average, or to the state average. The ratio is a useful metric for comparing each hospital's charity care contribution relative to its size. Overall, the ratios for all but one hospital are higher than the state average. ZSFG had the highest ratio at 9%. So moving forward, there are a constellation of state and federal policy changes along with global events that will influence charity care programs and their use. The onset of the COVID-19 pandemic and its attendant economic and health effects will likely impact charity care requests. These impacts will likely be long-term and alter the healthcare system landscape. In January 2021, a new federal administration assumed office. Based on President Joe Biden's platform, restoring, strengthening, and expanding the systems in place under the ACA will be a major priority. But looming over the agenda ultimately is the uncertain future of the ACA and whether the Supreme Court upholds or overturns the law, which would have serious consequences on people's access to care. San Francisco's Charity Care Ordinance has enabled the collection of a long history of data since 2001. The continued collection of this data, along with the new demographic data that has been collected, will help to provide insight into the impacts from these ongoing and potential future changes. So this concludes my presentation, and I'd like to acknowledge our hospital partners who have participated in the Charity Care Work Group and thank them for their continued support.
Thank you, Max. Commissioners, before you go into any questions, I want to check if there's anybody on the public comment line who would like to raise their hand to speak. A comment. Press *3 if you'd like to do so. All right, I don't see any hands raised.
You know, Mark, unfortunately, we're not seeing, of course, everybody because of this remote system, but I'm wondering, it would be nice to sort of acknowledge and ask if there are hospital representatives present, as I understand there are, if they would also like to say something in regards to this study.
Super. Folks, if you'd like to raise your hand to speak, because there might be so many of you. If you look at the bottom, those of you inside the meeting, if you look at the bottom of the screen, there is a little megaphone at the bottom, and you can click that to raise your hand, I believe. Commissioner Bernal and Chow, I have a different screen than you all, so I always get this wrong. Is that how you raise your hand inside the meeting?
Yeah, I don't see.
What I
don't.
Mark, what I get is there's the red circle with the X in it, and then there's another circle just to the left with 3 dots in it.
Oh,
no, wait, that's not it. Sorry, pardon me.
There's a little hand on my left side.
Oh, so sorry. I know.
Yeah, so
I'm sort of like not doing great here, but if you click on where do you go? Oh, if you click on participants on the lower right, and then a window will pop up on the right side where you can see the attendees, and towards the bottom of that window is a hand next to a megaphone.
Thank you, and I apologize I should know that. I apologize. But folks, if you'd like to speak from the hospitals, please raise your hand so that we can acknowledge you.
And it's possible that Mr. Guerra might even just name the hospital so that we can give him credit for actually coming to the meeting here, which we're really appreciative of.
Oh, great. So it looks like Gil.
Yeah. So I'm Gil Radke. I'm the representative for UCSF Health. I'm the director of patient financial services, and it's my first year participating on this survey, and it's been a pleasure. It was very educating to me and my staff as well. So I think that provide us, some insights in how can we actually provide more charity and be more flexible to our patients. So that's one of our goals for this year. Apply technology so that we can identify more recipients for charity care. So,
thank you, sir. Does any of our other guests like to be able to make a comment or just even be recognized? Because we really thank you all for coming.
Could the other folks at least speak up and let us know which hospitals are represented today?
And if they're having trouble participating, I can see that ZSF, Janine is here, and also Kaiser has 3 representatives that are here as well.
Hi, it's Shiana. I just unmuted myself. Can you hear me?
Yeah. Yes, we can.
Great. It's nice to meet all of you. I appreciate the depth and breadth of the information that you've provided. And I looked through the report and have checked in with many of my colleagues, and we're all very excited to have been able to provide the information we provided. You know, at Kaiser Permanente, it is part of our mission to provide quality and affordable healthcare services. And we also make sure that we work hand in hand with the communities that we serve. And so it's a pleasure to be able to do that through our charity care programs. And, you know, every year we look closely at the criteria and at the members and non-members that we serve through charity care, and make sure that we're holding ourselves accountable to furthering our mission. And I think you can see that when you look at the 2 years of data, that we expanded our reach a little bit year over year. So we hope to continue doing that. Thank you for having us.
Thank you. All right. Anyone else? So commissioners, any more questions from you or any comments?
No questions here.
Okay, so I have not realized, but it's now like about 20 years since it's
Please continue, Dr. Chow. I'm not sure if that was a stray sound coming out from somebody.
well, maybe somebody wanted to also make a comment, but this is really a very nice summary report, and I want to commend you for, first of all, giving the charity care landscape. And we remember, those of us old enough do remember when this was passed and was singularly, our city was really looking at this. Well, there was a nationwide issue concerning nonprofit hospitals. And since then, I think that the report has grown in its ability to allow us to understand, everybody here understand how much charity care is being delivered, and being able to understand also the different ways in which our hospitals actually do deliver it. And I'm particularly appreciative of the fact that, even though I guess it's because we had 2 years of lapse, that we were able to have a 3-year snapshot of many of the items on here. So a specific request I have for the report to the commission is that on your page 14 in your slide, you have hospital-specific data, which is only for 2019. I think it'd be nice to parallel that we follow the 2017, 2018, and 2019 trends. And I do think that this also will highlight that our very largest nonprofit hospital, CPMC, has really stepped up to the plate over these several years and have done a remarkable job. And even as they parsed out Mission Burnell, the old St. Luke's, which those of us who had concerns of merging the two data, where we could not see which of the two campuses were doing the charity care, that clearly both campuses have actually stepped up, and particularly CPMC's new campus, perhaps. Well, this doesn't reflect the new campus, but even before getting to the new campus, shows really a commitment to the city's program. So I think this can really show nicely if we also then look at some of the dollars in a 3-year snapshot, or maybe it's just the ratio. So I'd leave it to the department to figure out how they would like to demonstrate the 3-year trend under the hospital-specific data. And I think those of us who have been working with the charity care report would be quite pleased at how well our institutions have actually stepped up in taking care of the people. And I think your ability to point out that there has been a continued trend to have more charity care in spite of a number of programs having been put in, including the Affordable Care Act, is somewhat concerning and maybe beyond this report, but perhaps should require that our department think more about what this all means. And I think disturbingly is where you're showing that people with insurance is then applying also for charity care. And I know that you've said a few words about it, but I'm wondering if, and I didn't actually see it in the text as to, do we truly understand why a Medicare patient would then be considered a charity case? I mean, what would be the circumstances that that happens? Or even Medi-Cal, because they're fully covered for the work that any facility really does. Or is it that, well, of course, under Medi-Cal, we have the Medicare differential. So really curious because Medicare is supposed to be covering costs in all the facilities. So how is it that somebody who has Medicare then comes and says that I don't have payment? Now, it's possible it's co-payment that is lacking in certain things like the Part B. But I think if you have any insight into that, that would be helpful in terms of trying to analyze what we can actually be able to use in understanding the, I guess, the use of charity care. So one specific was on the hospital data. I think it would be nice to be able to show the trends as you have on many of the others. I guess my other area, because I think you've done a really nice job in summing up, and for yourself who was not, I'm pretty sure you're not old enough anyway to be at the beginning of the charity care program, that you've picked up the essence of what I think we wanted the charity care report to be, not just simply a recitation of and disclosure of what nonprofits do and therefore to justify nonprofit, but really to use it as a tool for populations. And so we added Healthy San Francisco for that reason, because that was another program that was sort of bordering on charity care. We moved people into it so that they were no longer simply on charity. And you have a very good report showing that Healthy San Francisco patients use emergency rooms less. And that actually was, I think, within the second year of Healthy San Francisco, a report that really made national headlines, that it really did work to put all of our citizens, all of our residents into a program, even the Healthy San Francisco program, which really showed off that you could reduce the emergency services. And it looks like that trend has continued, so it's really great. But the one thing I find lacking is trying to put in the report itself too, is trying to put the context of Healthy San Francisco for those who really didn't know what it was, and why we even have it in the charity report. And I know that means perhaps expanding that section a little, but I think it's sort of just sitting there without context. If people just came to the city in the last year or two, said, well, why are you including Healthy San Francisco? Because even though you have a definition for it, I think that some sort of discussion of why it was that we added Healthy San Francisco to the charity report would be appropriate for the future. So I didn't mean to really go on that long, but this is one of my favorite reports. I'm really pleased with the results that our hospitals have been able to show. And when we began this report 20 years ago, there was one very prominent hospital that didn't seem to show or was not able to demonstrate the good work they're doing. And now it looks to me like we've gotten everybody onto the page that we wanted, which was, first of all, to match the state average. and we've exceeded that in almost every hospital. So I just think, and we will say that at the full commission meeting when it comes before us, that I personally am very proud of our hospitals and what they've done. And my comments here are merely to try to improve the report a little, and particularly to fill out the section on Healthy San Francisco a little more, giving it the context as to why it's part of a charity report, as being one of the GAP programs that this city started in order to have a insured population for our county. So I think I'll stop there because we should get a response back from the author, and perhaps he hasn't taken kindly to those comments. So.
Thank you, Commissioner Chow. I really appreciate the feedback, especially given your historical knowledge of the ordinance and the reports that have been produced. With regards to your first comment, yes, we can definitely include more context regarding the number of years for, or 3 years for hospital-specific trends and in the summary sections and throughout the report as well, to make sure that information is there. With regards to your second question, about like why someone with Medi-Cal or Medicare might need charity care. Like you mentioned, there are sometimes out-of-pocket expenses or cost sharing that a patient may need help or financial help with providing for. And I do want to note that one of the things the report was able to identify since we collected health coverage data for the first time for, I guess, a 3-year period, was that there was an increase in Medicare patients receiving charity care. And one of the items that, or one of the factors that hospitals mentioned them seeing is that there's an increasing number of patients with Medicare Advantage plans that don't always fully cover the cost of care. And so patients have greater out-of-pocket expenses that then they may need to rely on charity care to provide for. And then with regards to your last comment regarding Healthy San Francisco, yes, we can definitely add more context about the Healthy San Francisco program, why it was established, and why it continues to be an important program, and a little bit more information about the services that it provides.
As you're checking, I'm just wondering, like on the Medicare program, in which there could be a gap because of the problem with co-payments, or and that wouldn't be just Medicare Advantage, because the traditional Medicare would have co-payments, and particularly if they didn't buy a Part B or something, or they couldn't make the first, was it 3 days of hospitalization or whatever it is as a copay. But I think that may be an area that we would like to sort of follow as a trend. I'm not sure how we do it, but it seems to be a growing problem, and that could help us try to understand that problem, just like we understand the Medi-Cal shortfall. So if there's a Medicare shortfall, we probably should try to understand that as part of this. And if we do, then what do we do about it? I'm not sure what we do about it, but it would seem to help that it's not like traditional charity of a person uninsured, right? So this whole area of the insured not having the ability to be able to receive care and needing hospitals to help them, I think is something that maybe in the next several years we all have to think more about, because that could cause, and we know employer-employee gaps are rising, right, like that, and in the commercial world even. So, but seeing your graph of seeing how there's such a big block that happened within Medicare as a percentage, it just seems to me that it could be something that perhaps we all, as we get back to normal, take the time to try to think out what do we do, because basically that's really, again, part of the uninsured, right? And is this something that kind of requires a change in public policy, a different way of looking at the co-payments for Medicare? Maybe it then becomes a federal issue that should be taken up because then people don't really have full insurance. Commissioner Brunel, since I went on with my monologue, now do you have any other questions?
You know, I do, Commissioner Chow, and I always appreciate your historical perspective, which always brings this, I think, into greater focus for us. So thank you for that. I did have one question, as Commissioner Chow had, I believe, rightfully stated when, with the inception of Healthy San Francisco, and the question relates to the utilization of emergency versus non-emergency care. With the inception of Healthy San Francisco, you would see particularly more people who did not have documentation getting into a primary care relationship rather than utilizing emergency services. And I'm wondering, when you look at the trends from 2017 to 2019, with charity care increasing and increasing most in terms of emergency services, you had brought up the affordability issue and people who are insured who couldn't pay co-pays or other things. Do you believe that means that there are more people who, because of affordability issues, did not have regular primary care visits or delayed care to the point where they would find themselves having to go to the emergency room?
Yeah, so I think it's harder to say whether or not there's more people that that have health coverage that are having trouble at affording care. What we can say is that a significant portion of people that do have health coverage are having troubles affording care, at least in terms of what I should say is a significant portion of the charity care population have health coverage but have troubles affording healthcare expenses. And because of the high utilization rate of, or the higher utilization of emergency care services, especially in relation to the Healthy San Francisco, I think it's indicating that, yes, that there's more out-of-pocket expenses associated with emergency care because it is more expensive, and that this population also might be less connected to primary and preventative care services. So therefore, they are dealing with much more emergent needs that come up in the emergency room.
Okay, I guess so. It's not necessarily that they are not seeking regular outpatient care, but that emergency care is more expensive, and that's why the expenditures are so much greater. For the increase in expenditures are so much greater in emergency care than in inpatient or outpatient.
We don't have data that is able to delineate between what's driving the expenditures by service type, but we do know that that emergency care is often more expensive on average than emergent care.
All right. Great, thank you.
And that allowed me to go back to the slide 12 here, which is really very interesting, because if I now look at the traditional care, and I guess, is this the first year we've done race and ethnicity?
Yes, yes. This is the first year that we've collected race, ethnicity data, age data, gender data, and payer status data for the traditional charity care population. And we collected 3 years worth of data from hospitals.
And you collected 3 years worth of data. So that includes the race data?
That includes the race data, yes.
Okay, so your race data is also only, well, let's go back. If we have, you had the nice trend in 2017 and 2019. I wonder if you could do that for the traditional charity care, because I find it interesting that the Asian population is marked at, well, maybe I'm reading it backwards. You say, which are the bars? Maybe that's what I'm confused about.
Mm-hmm.
The 2019 is the charity care, and the San Francisco is actually the population. Is that right?
I'm not entirely sure what you're referring to, but I can just walk you through the graph. That the bar on the right is, yes, the demographic breakdown of the San Francisco population. So starting with the bottom bar, 36% is the size of the proportion of San Francisco residents who identify as Asian. And the bar on the left is the bar of the most recent data from hospitals and the proportion of charity care identifying as the different race ethnicity categories. And I do want to note that for the 2017 through 2019 data, at least with regards to race ethnicity, we don't see a change in composition, that many of these percentages stay fairly stable. It's just as the increase in patients, or as there was an increase in patients, they increased evenly across the different categories.
Okay, so perhaps instead of doing another set of bars, we could put that in as a note that these are the same percentages over the last several years, especially since we are now looking at reports also with a racial lens. And so I think that would be helpful. Otherwise, I don't know if anybody else wants to make any further comments, but I really do appreciate the work that you've done. And I think this report has improved year after year. So thank you.
Dr. Chow, I'm not sure if there's anything else to say. You've covered it all. You were very comprehensive in your review and your comments. I would like to just offer, we've got two other issues, emerging issues and public comment, and then, is that okay? Then you can move on, and then there may be a pause before Commissioner Gerardo comes. Thank you very much, Max. And I'm sorry I switched your name when I initially introduced you. But let's move on to emerging issues. Commissioners, anything, or any folks on the public comment line would like to make a comment? Press *3. Anyone?
Mark?
Yes.
Mark, do we need public comment on the charity care report?
I did call, and I'm happy to say that again. If you'd like to make comment on the charity care report, which was item 7, please press *3 if you're on the line. Okay, no comments there. And then finally, for general public comment on item 9, please let us know if you'd like to speak by raising your hand, press *3. Okay, no hands. So I believe we are at the end of the business except for the Chinese Hospital Association contract, with item 5. And Commissioner Gerardo is not going to be joining us for another probably 5 or 10 minutes. So with your permission, Commissioners, we can take a pause. And Commissioner Chow, I believe that we'll say goodbye to you.
Right. So because I will recuse myself from item 5, I'd ask if Commissioner Burnell would then chair the remainder of the meeting.
Yes, I will.
Okay. So at this time, we'll call a recess until Commissioner Gerardo arrives.
Thank you all.
Thank you.
I will stay in the room and be here for anyone who pops up.
Okay.
Thank you, Mark. Thanks all. See you soon, Dr. Chow.
Yes, thank you.
And any DPH staff who are here, feel free to leave if you're not involved in the Chinese hospital contract. I know some of you are being polite and staying to the end of the meeting, but there's no need if you're not involved with that contract. Thank you. Welcome, Commissioner Gerardo. Thank you for joining us.
Sorry I couldn't get here earlier.
Oh no, we're so thankful that you were able to make time in your schedule to help us today.
You're right on time, Commissioner Gerardo. Thank you.
Hello.
Shall we reconvene from recess? Do we have Kelly Hiramoto here?
Yes, we do. Kelly is on, I think, just on the phone, or I'm not sure if we're in a video. But Kelly, can you speak and just say, give us some information on the contract?
Sure. This is a contract that was put in place for surge planning to provide discharge destinations for patients at San Francisco General Hospital who would ordinarily be referred to Laguna Honda or other skilled nursing facilities. And during surge time, there were a lot of skilled nursing facilities that were not able to do admitting because they were having their own COVID outbreaks. And Chinese Hospital had the ability to convert one of their acute care units to receive these lower level of care clients. And these 23 beds were put into service to receive lower level of care patients that were essentially SNF level of care, to take them out of an acute care bed to make sure that we had adequate resources at San Francisco General for any incoming patients.
Thank you. Commissioners, there's no one on the public comment line, so it's just you two in case you have questions.
I do have a quick clarification. So, hello, Ms. Hiramoto, how are you? So these are for non-COVID patients, right? To make room at the general or elsewhere, is that right?
It is for San Francisco General, and yes, it is for non-COVID patients.
Okay, great, thank you. Thanks for that clarification. Commissioner Gerardo.
My other question is, this contract is through June. Is that adequate?
Well, being optimistic, yes.
Okay. No, my only concern is, would you have to come back again in whether or not it would be through June or possibly through September? I mean, I don't know. I'm just.
Yes, I think if things do not go well, we would have to continue to extend that contract. We would ask to extend it till we got through the need for having sort of surge beds on standby. But at the time, we were anticipating that with vaccines rolling out and with better discharge outlets and other nursing homes hopefully being able to receive patients, that we will finish on time. But yes, you are correct that if there was a continuing surge or something unexpected, we would want to continue the beds for longer.
Okay, thank you.
So commissioners, if you don't have any other questions, then a motion and a second is all we need for this to be put onto the consent calendar.
Happy to make a motion to accept the Chinese Hospital contract.
And I will second.
Great. And Commissioner Gerardo, for these meetings, we don't need to go through and roll call because there's only two of you. So thank you very much. And then if you all could do the same thing for an adjournment, because that concludes the business of the meeting today.
Commissioners.
Thank you, Kelly.
Do we have a motion to adjourn, Commissioner Gerardo?
A motion to adjourn.
Second and adjourned.
Thank you so much, everyone. And again, thank you, Commissioner Gerardo. That was very generous of you to show up.
Thank you. Thank you.
Okay.
Thank you.
Bye-bye.
And Mark, can you stay on for a minute?
Yes, actually, because it's public, I'm going to call you. Is that all right? I'd rather not do this because it's a public meeting.
Yeah, call me because of my recusal needs.
Oh, sure.
I just want to.
Okay.
That's all.
Okay, bye.